Welcome to Hepatitis Decoded, a concise tour of global health challenges and strategic responses to viral hepatitis. Over the next slides, we'll unpack the disease burden, distinct transmission routes, clinical progression, diagnostic interpretation, and the public health strategies that can drive elimination, translating complex data into practical steps for prevention, treatment, and long-term surveillance. This slide summarizes the global impact and urgency. Hepatitis causes over 1 million deaths yearly, outpacing many familiar infections, and chronic hepatitis B and C account for about 80% of liver cancer cases, straining health systems. The incidence is rising in low-income regions, while vaccination, safe injection practices, and harm reduction lag, which makes a strategic public health response urgent and feasible. This page contrasts two very different transmission routes and tailored interventions. Hepatitis A and E spread via the fecal-oral route through contaminated food and water. So sanitation upgrades, clean water access, and hygiene education are critical. Hepatitis B, C, and D travel through blood, sex, and birth. So universal safe injection and transfusion standards, targeted harm reduction services, and vaccination for B are the primary prevention tools. This slide focuses on vertical transmission risks and prevention for hepatitis B and C. An HBe egg-positive mother can transmit HBV to an infant with about 90% risk at birth, while perinatal HCV transmission is much lower at around 5%. The pathway to near elimination includes antiviral therapy in pregnancy when indicated, timely birth dose vaccination, and hepatitis B immune globulin to break the chronicity cycle. The clinical presentation starts after an incubation period with signs like jaundice, dark urine, fatigue, and right upper quadrant pain. Most acute A and E infections resolve within 2 months, though fulminant hepatic failure is rare. Symptom likelihood varies by age and virus, and because mild cases still transmit, clinical suspicion must be confirmed with serology, PCR, and liver function tests, rather than relying on symptoms alone. This graphic traces long-term progression from persistent B or C viremia through necroinflammation, progressive fibrosis, and cirrhosis to hepatocellular carcinoma, with accelerants like alcohol, HIV, and metabolic syndrome. There's an antiviral intervention window where early detection, screening, and non-invasive staging can prevent irreversible decompensation, achieve sustained virologic response, and substantially reduce cancer risk over time. Interpreting hepatitis panels correctly guides vaccination, treatment, and contact management. For hepatitis B, HBsAg indicates active infection, while anti-HBs implies immunity from vaccination or past infection. For hepatitis C, a positive antibody must be followed by HCV RNA PCR to confirm chronic infection. IgM antibodies distinguish acute A and E infections, and accurate reading of these markers avoids unnecessary worry and directs appropriate care. This slide explains non-invasive fibrosis assessment using transient elastography and serum biomarker algorithms to replace biopsy for many patients with chronic hepatitis B and C. Results stratify people into treatment urgent versus monitor groups using KPA thresholds linked to fibrosis stages. The approach lowers cost and complications, streamlines resource use toward imaging and labs where they're most needed, and promotes broader access to staging. Hepatitis C therapy has been revolutionized by direct-acting antivirals, with cure rates over 95% in 8 to 12-week oral regimens. Simplified prescribing and pan-genotypic combinations like sofosbuvir-based or glecaprevir regimens make treatment scalable. But selection must consider genotype, cirrhosis, prior history, drug interactions with ARVs or statins, and reinfection risks when planning micro-elimination campaigns. For hepatitis B management, potent antivirals such as tenofovir and entecavir suppress replication, can reverse fibrosis, and lower cancer risk. Treatment duration depends on the patient profile. Cirrhotics usually require indefinite therapy, while some non-cirrhotics may stop after HBeAg seroconversion. Ongoing monitoring every 6 months with ALT, viral DNA, and HCC surveillance helps detect resistance or malignant transformation and optimize long-term outcomes. This strategic roadmap frames elimination by 2030. For hepatitis B, a birth dose coverage target near 90% is essential because safe, effective vaccines exist to reduce incidence, while hepatitis C elimination relies on harm reduction tools, syringe exchange, opioid agonist therapy, and sterile medical equipment, since no vaccine is available. Combining universal infant vaccination with targeted adult strategies and micro-elimination campaigns can drive the trajectory toward 2030 goals. The World Health Organization's 2030 targets aim for a 90% incidence reduction and 65% mortality reduction, supported by core pillars: test and treat with point-of-care RNA and affordable DAAs, universal vaccination including birth dose, and strengthened blood safety and infection control. Critical enablers such as sustained financing, civil society engagement, and robust surveillance are necessary to translate these targets into public health victory.